Hey, everybody. Today we're going to do chapter 33, which is pediatric assessment. When you have pediatric clinical, you'll notice under Nursing 213 on Canvas that I have this PowerPoint listed. It does not have the recordings, it's just some slides just to kind of familiarize yourself with some things. But here is the recording. So, chapter 33, pediatric assessment. So we're going to look at the different components of the health assessment, beginning with the health interview and the history, um, the importance of observing the parent and child interaction, all the different things that we need to assess, and then of course our physical assessment. So there's things that we assess besides the physical assessment that are very important. So whenever you come to clinical, for pediatrics, you'll see that you have a sheet of paper that I call the health history and pathophys. So I might refer to it as the H&P, but it's not the same as the history and physical that you normally think of. It's the history and your pathophys. So basically, the top of the form is the interview and the story that you got from the caregivers and possibly from the patient, if they're old enough to tell you, about what brought them to the hospital. How did their illness get to the point that they needed to be hospitalized? And I want you to tell that story in their own words, not what you got in a report or what is on the physician's progress note. I want to know that you went in the room and introduced yourself and broke the ice and asked the family and asked the patient, so what's going on? How is this your first time in the hospital? What happened? How did you end up getting put in the hospital? Tell me all about it. And I want you to talk to me in that format. And it's obvious if you really interviewed the family or if you copied it out of the chart. So while you're obtaining that history from the family, of course, you're observing the interaction between the parent and the child. So you may think that it's a given that the parent is comfortable talking in front of, that the child is comfortable talking in front of the parent and vice versa. But sometimes you see things that are odd. Um, Sometimes you see maybe a lack of eye contact, or maybe every time you ask the child a question, they look at their parent first for permission to speak, or sometimes there's nothing to it and the child is just shy and they're like, do I really have to talk to this person? And they look to their parents first. But regardless, you are naturally observing those things and becoming aware if anything seems out of the ordinary. Assessment of their emotional, physiologic, cognitive, and social development. So, one of the things that I ask you on your paperwork is, what is the child's cognitive and developmental age? So, if you were told that they were 8 years old, but you go in the room and they're in an infant crib and they're nonverbal, then most likely they have a developmental delay. And even though they are numerically 8 years old, are they really like an 8-year-old cognitively, developmentally, or are they more like a 1-year-old or a 2-year-old? Social development, we have we see a good number of children that have a wide range of delay. Sometimes it seems more social than anything else. The teenage patient that can't make eye contact, that has obvious anxiety issues, or seems abnormally shy, has inappropriate responses to you, where it makes you think about autism, Asperger's, and things like that. So all of those things impact the way that we care for the kid, and it's not just as simple as, oh, we're going to go in and take care of a 12-year-old, because it may be a little more complicated than that. And then you have your physical assessment. Before you can do a physical assessment, you have to establish trust. You've got to break the ice and connect with your patient and your family. For your child to allow you to do an assessment on them, it usually requires the child witnessing you establish rapport with the caregiver. Once they see that their mom or dad trust you and they witness you visiting and interacting with the parent, then they are much more likely to tolerate your presence. I don't know if this 1 o'clock in the morning recording is going to work because I'm starting to yawn. I didn't yawn until I tried to talk. So it goes a long way to walk in the room, make your observations, and work on establishing a relationship with the caregivers before you assess your child. And all of that naturally is assuming that you have time and that the child is not so sick that that you have time to chit chat with the family. Depending on the acuity level of your child, that may or may not be an option. Demonstrate respect for the child and the caregiver. What does that mean? How do you demonstrate respect? So it's something that we really have to remind ourselves of because of the generational gap. Not meaning to be insulting to anyone, but people in their 40s and beyond, even 30s, 40s, 50s, they have different expectations of how you should interact with someone that you've never met before, and how the younger generation should interact with the older generation. Not that all of the nursing students are in their early 20s. I'm not saying that, but it does tend to be a significant part of our student population. Please keep in mind the first step to gaining respect is good manners, and not only being polite, introducing yourself, respecting the atmosphere in the room if they're sleeping, or not flipping on the light, not being loud, not laughing inappropriately whenever obviously the family is stressed out to the max and emotional, things like that. So just be aware, no matter how eager we are or how excited we are or how comfortable we are, we have to show the proper respect, because we're not their friends. They don't know us like that, and we don't know them like that. We don't want to be cold, and we don't want to be so standoffish that it's just weird, but we've got to begin the right way. Listening. I have to work on this. I'm much better at talking than I am at listening. And the Bible does talk about how, the wisest people in the world are the ones that listen and don't talk, and they keep their mouth shut. I know it doesn't say it just like that, but I'm sure you know what I'm talking about. And I scold myself all the time because I think how dumb I must be and how opposite of wise I must be because of how much I talk. So it's something that I strive to get better at. We must actively listen. Okay. So if we do all the talking, we're not listening to what they're trying to say. We're not reading between the lines. We're not hearing their words. We're thinking of what we're going to say next. We're assuming we know what they're going to say. That's where I mess up. I think I can finish everyone's sentences, and I'm impatient. I can't stand it when people talk slow. I don't have time. My brain doesn't doesn't work on that level. I wish it did, because it would save me a lot of heartache if I would just shut my mouth. So while you're listening actively, you are demonstrating empathy with the right cues, facial cues and expressions, making eye contact, showing them that you do care and you empathize with what they're going through. And you do that by providing appropriate feedback. Once you get ready to do your physical assessment, you need to be systematic as much as possible. So it doesn't always work exactly the way that you would like it to for every exam. But when I say systematically, there are certain things that out of habit, I have created the habit of doing certain things first every time, and trying to remember certain things to end with. The middle may get a little jumbled, but we need to have a goal. For example, on an infant, the first thing that I do, besides my observation of, are they awake and alert? Do they arouse easily? If they're resting with their eyes closed, are they easy to wake up? If they get fussy, are they easy to console? Once I do that, basic neurological exam from the doorway there, and I start to put my hands on the patient. With an infant, the first thing I do is put my hand on their head, and it looks like I'm just saying, "Oh, what a cute little puppy," and petting them and seeing how soft their fur is on the top of their head. But really, I'm palpating the anterior fontanelle, and I'm feeling the temperature of the skin. I'll move from there to their hands and assess capillary refill and attempt to feel some radial pulses. As soon as possible, that will remind me to also do the pedal pulses. But of course, distractions happen. Infants start crying. You might pick them up at that time. So you just kind of have to be going through your assessment in your head, thinking, okay, I need to get back on track. What comes next? One of the last things that I do is open the diaper and check for a diaper rash. I think about it how, when I document in my narrative notes, one of the last things I document is voids and stools per diaper, and about the skin assessment in the diaper area. And after that, when was their last bowel movement, things like that. And after that, it's just my safety issues and closing my note. So the things that come in the middle sometimes change a little bit. Now, is it always that way? No. If my infant is sleeping when I first walk in, and while I'm talking to the parents, the baby doesn't wake up, what's the first thing I'm going to do? I'm not going to go pet them and wake them up. First, I'm going to put my stethoscope on their chest through their little onesie, and I'm going to listen for a heart rate and a respiratory rate, for a murmur, for breath sounds, and for bowel sounds. Hopefully, all of that can be done before I wake them up. So you just have to use some common sense. Validate and interpret your data accurately. So that means if your baby is on the monitor and it shows a heart rate of 145 and it shows a respiratory rate of 90, am I going to write down a respiratory rate of 90 without manually assessing a respiratory rate? Heck no. Respiratory rates are very tricky when it comes to monitoring with telemetry leads, because every little movement, the apical pulse, all sorts of things can be interpreted as a respiration. So I'm going to validate my data and make sure I interpret it correctly. That's one example. Another example would be if my infant is crying, is it because they're hungry, or they need their diaper changed, or they're in pain? What is it? Am I going to record a respiratory rate of 70 when I counted that respiratory rate when they were crying? That's not a good idea. That wouldn't be valid. that would be skewed because of what was happening at that moment. I want to get vital signs that I can validate, that I can interpret as a true representation of their physiologic state, their respiratory illness, or whatever's going on, not something that's affected by um, extraneous circumstances at the moment. So I'm going to pause this for just a minute and see if I can correct the lack of subtitles. So we'll see if it works now, but it may be an internet problem. I think that it is, and I apologize for that. So here's some pointers for when you are nervous and you first walk in the room. Start by telling them who you are, why you're there. You're a nursing student and you're assigned to their child. We're going to be here until around lunchtime today, and we're just here to help their regular nurse. So we're just going to get some vital signs and do an assessment and try to answer questions and assist them however we can. As far as providing privacy and minimizing distractions, the number one thing that comes to mind there is shutting the door. Don't leave the door open, especially if they are on any kind of isolation precautions. It's a big deal to keep the door shut. Begin with open-ended questions, and that takes me right back to, so what's going on? What happened? Tell me what happened. That's all you got to say. They have a story to tell that they can't wait. And, they're in there by themselves and they really want to talk. The parents usually really want to talk. They may need a minute to get woke up, but once they're awake, they're usually good about it. Use specific questions to clarify. As they're answering your open-ended question about what happened, you can use your specific questions to clarify and make sure you understand. Keep it to one question at a time and don't ignore the child. Be sure that you look at the child, use your facial expressions, take a minute to ask them to elaborate, or depending on the age of the child, say, oh, that must have been scary, or, oh, wow, what did that feel like? Sometimes the older kids will do all the talking and the parent just nods their head and agrees, or may interject every now and then, but you would be surprised how, especially the school age children, they want to tell their story. Never forget to always be honest with the child. We don't want to be so blatantly honest that we tell them things that we really don't need to tell them, that are just going to scare them. But we're not going to lie. We just have to word things in a gentle way while telling the truth. But we do not want the child to catch us in what they consider a lie. If they think we weren't honest about what was going to happen or what to expect, then you have lost any hope of gaining their friendship and trust. True or false? The nurse is eliciting a health history from an adolescent. It is recommended that the nurse acts like the teenager's peer in order to gain respect and acceptance. So those of you that have been around teenagers, either in clinical or maybe you have teenagers and you've hung out with their friends before. Honestly, when you walked in the room of your teenage patient, how did you talk to them? How did you start asking them questions about what brought them to the hospital? Part of you, well, I'm speaking for myself, of course, because I don't know what you're thinking, but for myself, part of me is thinking, I'm going to be relaxed. I'm going to go in and just show them that I get it. And I've got a teenager and we're all, buddies here. Well, the literature says that if I go in and say, what's up, homie? and fist bump them when I first walk in, that is not the way to gain their respect and acceptance. So I guess what the teenager wants from you is more of, teenagers think they're grown, but when they're in a vulnerable state, like in the hospital, what they want from their nurse is an adult. They want a responsible caregiver, someone in that caregiver role that they can trust to do the right thing and make good decisions for them. And once you've developed that relationship with them and they know they can count on you, then the fist bumps are okay. The next day when you come in, sure, go for it. That's my personal opinion. But just don't start out that way. Um, the teen will not accept you as their peer, no matter how hard you try. You're not in high school. You are not their peer. It will never happen. So what they see is you trying to be fake. And maybe you're acting that way because you're trying to hide or cover up the truth, the horrible truth, from them, and that something bad is looming in their future. So just be respectful to the teenagers. So here we have a family. This family have brought their son, their 1-month-old son, to the physician for his wellness examination. The baby's name is Kim. Kim is the second child for the Hans, this family. They're the Hans. They are Chinese Americans who moved to the United States 4 years ago to study at the local university. Kim's labor and delivery were unremarkable. So the baby is Kim. The family is the Hans. He was full term, no problems with labor and delivery. What components of the health history will be important for the nurse to collect before examining Kim? So I kind of just mentioned some of the health history that's important. I want to know, was Kim premature or was he full term? Was there anything unusual that happened when he was born? Because a full term baby can still have complications. Think about the kinds of things that you might want to ask. Does mom breastfeed? Does she formula feed? Does she do some of both? Does the baby have any problems going to the bathroom? Has he ever been in the hospital before? Any kind of, just all those kinds of questions. Are we up to date on vaccinations? He's only a month old, so he hasn't gotten his 2-month-old shots yet, but did he get a hepatitis B shot in the hospital and any other vaccinations at birth? And then how should the nurse approach the baby when we're ready to start our exam? How do we start? Mom's holding the baby. Do we take the baby out of mom's arms? How do we begin? What do you think? Would you take the baby away from mom at the very beginning of your exam? What could happen if you do that? Well, you could end up with a crying baby, and any hope of hearing breast sounds easily and counting an apical heart rate and respiratory rate have just gone out the window. So if mom's holding the baby and the baby's content, I would go ahead and get my heart rate, respiratory rate, breath sounds, and abdominal sounds before the baby gets upset. I will assess my anterior fontanelle. We will talk more about that shortly, about all these different pieces. My skin, pink, warm, dry. I can even raise the gown up and actually look at the work of breathing. That's something that we have to do. We have to raise the shirt up on all pediatric patients and assess work of breathing. I can palpate the tummy. If I can't open the diaper from that angle, I might get mom to lay the baby in the crib or just reposition the baby so that we can check the diaper area. Look over the skin, ask mom if there's any unusual birthmarks, Mongolian spots, anything unusual there. Feel my pulses, check my cap refill. If we have an IV, I can pretty much do everything with the baby in the mom's arms. What's the difference in a review of systems and a physical assessment, by the way? The ROS, the review of systems. Is there any touching involved in a review of systems? No, it's just asking questions about each of the different body systems. And that usually happens prior to the physical exam. It's mainly something that we see the physicians document, but it helps you to understand as well. But we do it too on some parts of our assessment as well. But like the parts that it says, do you have a history of any of these things? And they say, no, 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 no. Do you have a history of this? No, 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 no. That's review of systems. Pieces of the health history that we want to get include the demographic information, where are they from? Where do they live, as far as, do they live in town or in the country? Do they have well water or city water? Do they live in an older home or a new construction? Yes, the physician asks these questions during the initial H&P, but it's important that you understand that these questions are being asked and where to find that information. Why would it matter if they lived in an older house versus a new house? I'm all about some old houses, but something you have to think of is lead paint. And when you have toddlers and babies that love to put things in their mouth and the lead paint is chipping off the windowsill, then that can be a problem. We're going to, of course, find out what is the chief complaint. What brought them to the hospital today? Why did they come today? History of present illness. What led up to this, any significant past health history, family health history, certain races tend to, I don't know if that's the right word. So races or ethnicity is the right word, probably ethnicities. Like people of Mediterranean descent are more prone to have beta thalassemia. We know people of Caribbean and African descent, and some other countries that are located in coastal areas are more prone to sickle cell disease. So there are certain things that could be passed down in the family, from bleeding disorders to a variety of other things like cystic fibrosis and different sorts of things that it's important to know family history about. Family composition, who all lives at home? Mom and dad, mom and mom, dad and dad, grandma and mom, mom and sister. Who's there? Who's important? Who's the primary decision maker? Who works? Who stays at home? What kind of resources are available? If mom doesn't work and she has 7 kids, does she have assistance that is helping to provide for these kids as far as diapers and formula and things like that? So when you start to get uncomfortable and you think that's none of my business, take a minute and think, why might it be my business? Well, if the mom didn't have money to buy the baby food, it's your business. If they're there in front of you at that time and you have the ability to connect them with the help that they need, it's your business. So, um, let's see, what else do I need to talk about? So, allow the mom to hold the baby during as much, or the dad, as much of the assessment as possible. Leave anything that's going to be invasive or even slightly traumatic for the end, such as if you have to look inside the ears or the mouth or the throat, save that till the end. Um, when you're checking your reflexes, for example, the Moro reflex is your startle reflex. You wouldn't want to check that at the very beginning and startle the baby, and you're going to have a crying baby. When you handle the baby, you want to use a firm, gentle pressure to make them feel secure. Always make sure you warm up your stethoscope, especially if you're going to be skin to skin. But I usually try to go through the gown or through the shirt, and I don't have a problem with that. Perform that assessment as quickly and completely as possible. And the more practice you get, the faster you'll get. Less than a minute. That's your goal. Head to toe in less than a minute. Use a soft voice. You're talking baby talk, you're smiling, you're making eye contact with the baby, all those developmentally appropriate things. Um, Offering a pacifier if the baby's crying. You're going to ask mom about if the baby has been gaining weight and growing and doing those developmental tasks that are appropriate for a 1-month-old. Are we able to hold our head up yet? Things like that. Is there is the baby making eye contact? Does he turn his head when mom talks or dad talks or the little brother talks? Those are signs that the hearing is intact. Just some different things to think about. So when we're assessing the family dynamics while we're getting this health history and doing part of our physical assessment, all of this is happening at the same time. Does the parent make eye contact with the infant? So why wouldn't a parent make eye contact with a baby? You've got postpartum depression, you've got um, young parents, you've got older parents. You have no idea what's going on in their lives. Was this baby wanted? Maybe the baby was originally wanted, and now because of circumstances in their life, um, they're having a hard time connecting with the baby. Maybe the baby has been in the NICU for the last 3 months, and all of a sudden mom lived 2 hours away and got her updates over the phone. And now all of a sudden it's time for the baby to go home. She took the baby home, had the baby for 2 or 3 days at the house, and now the baby's sick and back in the hospital again. She feels like an utter failure. She doesn't even know this kid. Somebody else has been taking care of it for 3 months. She gets a premature baby, probably with complications. Maybe is a difficult feeder, has bad reflux, possibly has a G tube. We don't know what kind of problems he went home with from NI. You expect this mom to take care of this baby, don't know what her support system is. She hasn't bonded with the baby, and now the baby's sick again, and she feels like it's her fault. Maybe she has even lost infants in the past. She's had, babies have died. So there could be some serious bonding issues, and they aren't going to come out and say, by the way, I had 2 or 3 miscarriages before this baby was born. Then I finally got pregnant, and this baby was born at 26 weeks and was in the NICU for 2.5 months. And I really don't really know this baby, and I really don't want to get attached because of all the things I've been through. They're not going to come out and tell you all that. What you might notice is that they don't make eye contact. Maybe they don't respond to the baby's needs. The baby cries, and the parent, either doesn't anticipate that, hey, it's time for the baby to eat. And of course, they're about to start crying. Can't you see that they're getting, restless and the baby's starting to root around? Those are things that we need to pick up on. And then, of course, you have the temper tantrum. Are they ineffective? Which many of us are. Do their comments increase the child's self-esteem, or do they belittle the child? So you can't fix everything. You can't necessarily fix it, but it's something that we need to recognize, because as we try to help the family and we try to help the child, knowing that our big role as a pediatric nurse is to educate the family, how are we going to get them to comply and to listen and to comply with what we're asking them to do without understanding the family dynamics there? Um, if they're always berating the child, what can we do? Um, we can kind of tune the parent out and focus on the child and build the child up every chance we get. Praise the child for jobs well done, even small things, the smallest thing. Praise, praise, praise. And hopefully, the parent will just get it through observation without you ever having to say, it's really not necessary for you to talk down to your kid. They will, they're perfectly capable of responding to positive reinforcement. So we just have to use our actions as our teaching tools, because if we use our words, we run the risk a lot of times of making the parent defensive, and they'll shut down. They won't listen to anything we say after that. So I'm not saying that you should never use your words. Of course, there are times when you have no choice, but if at all possible, I really recommend that we teach through example and through our actions. So our behavioral observations are crucial to proper assessment of the family's needs. That's what it's all about. We've got to observe these things that they're not going to offer, this information that they're not just going to come out and say. We can pick up on things, on cues that can lead us to the right questions that we can ask, to explore some areas further if we think that there may be something there that that we that maybe they'll talk about if we just pose the right question. So where do I begin? So we've been talking now for about 35 minutes. I think what we're going to do is stop here at this slide, and I'm going to upload this part of the recording, and we'll break it down into sections. And when I'm not yawning so much, I will tomorrow finish recording some more slides and get them posted for you. See y'all later.